and good afternoon. I'm Javed Iqbal. We have met a few times over the last couple of days. I'm thankful to Solis Pharma for inviting me to talk on bisphosphonate use in arthroplasty. I'm not the expert in bisphosphonate use, but certainly with the process of forming this presentation, I've become more informative. And I'm grateful to my fellow, Zohaib, and my postgraduate trainee, Ehtisham, for helping me in this presentation. I've got no disclosures to make. So if we look at a bit of history, Von Bayes, he first reported the synthesis of the bisphosphonates in 1897, and nearly 70 years later, first bisphosphonates was used in human. Bisphosphonates are basically the analog of pyrophosphates, and there are two main types of bisphosphonates. One is nitrogen containing, and the others are non-nitrogen containing bisphosphonates. The nitrogen component is important because that prevents the degradation of the bisphosphonates. And as we all know that the impact of the bisphosphonate can stay for many years, even up to 10 years, and the baseline reason for that is they don't get degraded in the body, and hence they can stay for a long time. So how do bisphosphonates work? The two main mechanisms of their working, and basically the summary of that is they inhibit osteoclast bone resorption. And we all know that all bone resorption in the body, whether that related to osteoporosis or any cancer or anything, finally is related to the osteoclast. And bisphosphonates basically inhibit the osteoclast either by preventing the formation of the osteoclast or in enhancing their apoptosis. And they got affinity for the calcium, and they get concentrated around the area of bone resorption, and hence under the ruffled border of the osteoclast, and hence get taken up by the osteoclast, and that leads to apoptosis. Generally, when do we start bisphosphonates? Postmenopausal women or men over 50 with hip or vertebral fractures, when the T-score is worse than -2.5, or if the T-score is between -1 and 2.5, but there is significant fracture risk according to FRAX score. If we look at the evidence, bisphosphonates and osteoarthritis pain, and there are a number of studies showing that actually bisphosphonate reduce the pain of the osteoarthritis as compared to placebo. Now, the role of bisphosphonates in total joint arthroplasty. As we all know from the various talks from this morning as well, that arthroplasty patients are more prone to osteoporosis, and that is because of their age, their low mobility, and bisphosphonates significantly lower the risk of total knee arthroplasty, i.e. the need for knee arthroplasty when they are started preoperatively. And one of the studies showed 25% lower risk of requirement for knee arthroplasty in those patients who were using bisphosphonates as compared to who were not using it. So again, this study shows that the osteoporosis is common and undertreated prior to total joint arthroplasty. And this study found that 86% of the total joint arthroplasty patients were having low bone density, but only 18% of those had been screened within 2 years. And just about a quarter of those were on treatment. So what the effect of the medication on the incidence and the risk of the knee replacement and hip replacement in this systematic review, they again showed that compared to non-users, the bisphosphonate users had reduced risk of needing joint arthroplasty. Now, another benefit of the bisphosphonate is in post-knee replacement. As we all know, that aseptic loosening is the #1 cause for revision surgery and knee replacement surgery. And the basic mechanism of aseptic loosening is ultimately through the osteoclast bone resorption. And bisphosphonates work through stopping that mechanism. One of the studies showed that after use of alendronate during first year, there was a significant increase or less decrease in the bone density around the knee, i.e. distal femur and proximal tibia. However, when you actually start seeing loosened lines, when you start seeing loosening, there is not enough data to show if the osteoporosis treatment at that stage can stop further loosening. Now, bisphosphonate and periprosthetic bone loss. Again, this study shows that the overall moderate evidence to show that there is a decreased bone loss in the proximal tibia and the distal femur if you are using bisphosphonates. Another similar study showing zoledronic acid and denosumab for periprosthetic bone loss, significantly there is a decreased bone loss or in those patients who are using bisphosphonates as compared to those who are not using it. Again, similar study showing, which is a result of combined meta-analysis of the 5 RCTs showing very similar results at 3, 6, and 12 months. However, when you go beyond 12 months, results are not very different. Looking at the result on early migration in total knee replacement, again, very similar results that early migration is less in those who are using bisphosphonates. Looking at the overall revision rate, this meta-analysis shows that overall revision rate for any cause is less in those using bisphosphonates. So I'll go through these slides quickly, but in summary, increased radiographic and histological bone ingrowth in those patients who are on bisphosphonates. There's a decreased osteolysis and implant loosening, and there is a decreased early implant migration and decreased risk of all-cause revisions in those patients who are on bisphosphonate as compared to those who are not. And bisphosphonate usage in osteoporosis and osteoarthritis patients decreases the joint pain and can decrease the risk of requirement of knee arthroplasty. Thank you.